Hi, thanks for joining us for the next module. I'm really honored to be here with the panel of Dr. Siegel and Dr. Joe Marola. I'm going to turn our attention to psoriatic disease comorbidities. So we're going to talk about some of the latest data that we have on comorbidities. This is really an emerging field now. We're really understanding more and more about psoriatic arthritis and really more beyond the skin and the joint disease. So it's not as simple as we hope. This is really a systemic disease, and this is why the science of comorbidities in this area has really grown. So let's take us back to the definition because this can be somewhat a little bit confusing, but a comorbidity is a disease or a condition that coexists with the primary disease. Here we're going to talk about psoriatic arthritis. But it can also stand on its own, and that's sometimes important to think about while we're talking about these different comorbidities. So here's a nice sort of cartoon picture from head to toe going over the more common comorbidities. It's not, completely comprehensive, but these are the more common comorbidities, which we'll try to take a deeper dive into some of these. But it'll be difficult in this, next 20 minutes to really go over all the comorbidities, but it's important to note that we're learning more about it, and we'll go over the ones that are a little more common. So here's a bit of a confusing slide, but this is screening consideration. So as we talk about comorbidities, how do we even find them, right? So we have to, it's almost like a new way of taking care of your patients. In addition to looking at disease activity for skin and joints, we also have an obligation to screen for these comorbidities so we even know that they exist and that may need treatment. So here's just sort of a short list, but we'll go through some of these as well in more detail. And then again, why is it important, as we have, less time and more documentation heavy needs during a visit, and then to also look at comorbidities can sometimes be a little overwhelming. However, it does become important because it could affect our treatment choices, it could affect the patients in different ways. So I think screening for comorbidities is going to be the way that we can treat them more comprehensively. So here we have an example, uveitis, which can occur in our patients. As you can see, monoclonal anti-TNFs may be better than the receptor antagonists. I'm looking at IBD and coronary artery disease. As you can see here, there are also nuances to our treatment choices that we make based on some underlying comorbidities. So here is from the GRAPPA treatment guidelines, which are going to be updated soon. I decided to hone in on a graph that's specifically for comorbidities in the GRAPPA treatment domain guidelines. So here what you see is a list of many different DMARDs that were commonly used across the top, and then the number of comorbidities that you can see on your left-hand side. And what these colored boxes are telling us is that A, there seems to be a lot of missing boxes, so obviously not every comorbidity is being examined with every DMARD, but in general, the green boxes, which you can kind of see in the middle there, are approved for primary use and also for both the comorbidity as well as for psoriatic arthritis. And then as you go down to the different other color-coded columns, you have proceed with caution, you have off-label use. So these are the areas where we're learning more about how they affect comorbidity as well. So how did we get to kind of even understand, comorbidities more? So this comes back to, does having psoriatic arthritis shorten your life? So we are going to look at some mortality studies, and I'll show you why this is important to comorbidities. So the mortality studies in psoriatic arthritis are really conflicting in a way. And we don't have as many as we do in rheumatoid arthritis. But here we have some observational studies that use something called an SMR, which is a standardized mortality ratio, which sort of evens out the statistical analysis of mortality studies. And those show some demonstrated increase of mortality. But then we also have cohort studies, some large studies with psoriatic arthritis following them for over 20 years. And we see that it does not really lead to an increased mortality. So the studies are conflicting, but what's really important is that these studies show they went beyond and they said, so why are these patients dying prematurely when they do? And that's when we found out that they were predominantly, sometimes in cases greater than 50% of the time, dying of cardiovascular comorbidity. And this is what really generated and started a lot of the cardiovascular literature on both rheumatoid arthritis and psoriatic arthritis. So here I just highlighted one of many cardiovascular studies that are out there. But here we see that up to 43% have an increased risk of developing some sort of cardiovascular event. And this is what really generated a whole host of interest in many people that are looking at this scientifically, trying to figure out what is that connection. The mechanisms are not well, examined, but they are really interesting that majority of the people that are dying early with psoriatic arthritis are due to cardiovascular disease. And so when we look further on this meta-analysis, we see that 55% increased risk of developing incident cardiovascular event. So during the time, new cases of cardiovascular event. And then the risk of myocardial infarction goes beyond that. So most of them are MIs, but you can also see strokes and you can also see heart failure. So different types of cardiovascular diseases as well. So in addition to knowing that, we also know that some of the treatments that we are giving our patients can also increase your cardiovascular risk. So what I mean by that are chronic NSAID use. So many of us do add that. It is the first line treatment for psoriatic arthritis. We do have some major prospective studies such as the Precision trial that has looked at a cardiovascular risk, not so much in psoriatic arthritis, but in RA and OA. And we also know that biologic DMARDs can sometimes mitigate some of those inflammatory effects and perhaps maybe reduce some of those risks. So I thought before I go on, maybe I would tap on Evan and Joe to say, in terms of NSAIDs, that's sort of a catch-22, right? We have patients that need to use it on a daily basis, yet we have some evidence that NSAIDs can maybe increase our risk. So I was just curious how you guys, do you encourage the use? How do you monitor the use? Just wondering, Evan, if you had any thoughts on that.
Yeah, Elaine, I would say that, early on in patients with active psoriatic arthritis, I'm really almost always using NSAIDs unless there's a strong contraindication, monitoring it carefully, advising them to have their blood pressure checked carefully, monitoring for GI toxicity as well. But over time, as we get other more effective disease-modifying agents in place, it's one of the first things that I get rid of. Obviously, if for some reason we've needed to use steroids along the way, I get rid of steroids first, and then I'll get rid of NSAIDs and try to use them on a more as-needed basis. I will say that I've often been surprised at the role that NSAIDs do play in patients' day-to-day comfort and day-to-day anti-inflammatory effect. I usually am thinking, well, just get rid of the NSAID, your biologic is taking care of everything, and lo and behold, we stop the NSAID and they come back 3 weeks later saying, my God, I'm in bad shape. So it's really individualized to the patient, but constantly keeping in mind the potential toxicity, especially the cardiovascular risk.
I agree. Joe, do you have anything to add to that?
I tend to agree, and I two other things I'll just mention. I think one is I find like many of us, I find the trying to quantitate how much NSAID they're needing, I think is also sort of a helpful marker for me of should we be revisiting our discussion around do we need to optimize other non-NSAID management options. So I think there's a sort of a metric benefit to quantifying NSAID use over time. So that was one comment. And the second is, I think, to prevent from unnecessary rapid cycling through medications, including when I've gotten their skin, say, under control, and maybe there's a little bit of intermittent musculoskeletal pain popping through. I think it's a great place to be able to, utilize an NSAID, say, to keep an otherwise pretty well-functioning therapeutic on board and keeping the patient happy. So I think they have their place. I share everyone's concern and caution. We certainly have discussion around cardiovascular disease, hypertension control, et cetera. But I certainly still see the role of the NSAID.
Excellent. Yeah, that's sort of the science and art of medicine, right? So balancing that risk-benefit ratio for our patients. Thank you. So let's go on to an associated comorbidity with cardiovascular. So probably heard a lot about metabolic syndrome. So here's the definition. It's central obesity plus one of the following abnormalities. There's really been a lot more study in metabolic syndrome as well. We know this is accelerated by this pro-inflammatory state, and patients with psoriatic arthritis, unfortunately, do and can have a low-grade systemic inflammation, which can then just augment insulin resistance, fatty liver, also contribute to further obesity, as well as elevated TNF. Just really resulting in a, sort of not a great ratio between elevated leptin and adipocytokines as well, furthering the insulin resistance theory. So in our patients with psoriasis and psoriatic arthritis, a study that came out of my group was trying to look at that metabolic syndrome along with something called a carotid intima media thickness, which is a early surrogate looking at an ultrasound in your neck, looking for early surrogate markers of atherosclerosis. So we looked at the relationship between someone with psoriasis skin alone versus psoriatic arthritis, the skin and joints involved. And what we found is patients with psoriatic arthritis actually had worse metabolic syndrome and carotid intima media thickness. So perhaps having a two-hit hypothesis could be worse than having skin alone. But unfortunately, both groups did have an increase in metabolic syndrome. So along the lines of cardiovascular disease, metabolic syndrome is obviously the role of obesity. And as you know, this has been a public health concern with even people without psoriasis in the general population. But I'm going to hone in on psoriasis and psoriatic arthritis, and we do see that there's a meta-analysis here of 16 studies, over 2 million study participants. And unfortunately, this is showing an increased risk of obesity in patients with psoriasis. And as the psoriasis increases in severity, we also see that obesity also increases in that group. Then we look at weight loss. So what does weight loss possibly have to do? If we know that obesity is not good for psoriasis and psoriatic arthritis, could weight loss possibly reduce the severity of psoriasis and psoriatic arthritis? This is an interesting study looking at 6 RCTs, 1 RCT in psoriatic arthritis, and some cohort studies, all looking at different ways to reduce weight, whether it be by diet or exercise, whether it be by gastric bypass. And all of these methods of weight loss did decrease the severity of psoriasis and psoriatic arthritis. We also looked at psoriatic disease in general through a really large network in the UK. This is over 70,000 patients. And once again, evaluating the relationship between BMI and risk of psoriatic arthritis among patients with psoriasis. So here the conclusion here is as your BMI increased, so did your psoriatic arthritis incident rates. So they concluded that obesity is associated with an increased rate of incident new cases of psoriatic arthritis. The other big area that I want to stress is not only obesity in itself and trying to lose weight, but obesity has an impact on your therapy therapeutic response. And that's really important to know because sometimes we have that really difficult question in the office about how do you, improve their obesity. You're short on time, you have all these other comorbidities. But I think it's important to note that patients that are obese compared to patients that are not obese, their response to therapy is not as good. So losing weight is not only important for cardiovascular health, but could be important for your therapeutic options as well. So then let's turn our attention to physical activity. So what can we do to help them? So here is a really large study of over 85,000 nurses in the Nurses Health Study, following them for 14 years without psoriasis, following their physical activity. And as you can see here, either 105 minutes of running or 180 minutes of doing something like swimming or playing tennis can really reduce your risk of psoriasis by up to 30%. So I thought that was really interesting study looking at obesity and trying to decrease your obesity. Then we look at other factors that there's a lot of studies on looking at the impact of smoking. So the question is, what does smoking really? We all know that smoking is not good, but now we even have vaping. And the question is, what's the effect of treatment on psoriatic arthritis? And once again, in these study that I presented here, this observational cohort study showed that heavy smoking could really decrease the treatment effect of anti-TNFs in patients with psoriatic arthritis. So it's just another comorbidity that we think of, another wellness strategy that we can do to decrease their their poor habits and making their psoriatic arthritis treatment better. Now, another emerging issue is fatty liver. So what's the link? So this is a newer comorbidity that we're looking at, and unfortunately we are seeing a huge link between, especially with psoriasis and fatty liver. As you can see here, there are common risk factors for this, being, it's hard to tease out, psoriasis versus obesity versus insulin resistance versus that metabolic syndrome that I just talked about. But all of this is driving low-grade inflammation, which then drives this vicious cycle of where liver damage and progression of liver problems can occur, an area that we should probably be looking a little bit more as. And quite honestly, I have not been, screening as much for this. Here's a particular interesting study looking, more recent one, looking at a longitudinal cohort, looking at psoriasis and systemic therapy, and also showing once again that there is fatty liver highest in, the psoriasis patients with systemic therapy, as well as psoriatic arthritis on systemic therapy. So what they found is the risk of incident liver disease is quite significant in psoriasis and psoriatic arthritis. So I thought maybe I can have Joe and then maybe Evan, maybe chime in on how, you might be looking at this liver disease in our group of patients.
Yeah. So Elaine, I have to say, I grew up with the dermatology mindset of being so aggressive. We used to keep every milligram written on a piece of loose leaf and stapled on the inside of the paper chart, and we would be sending people for routine liver biopsies, at cumulative time points, 1.5 grams and 3 grams, et cetera. So obviously we've moved away from that. We don't do routine liver biopsies, but I've been impressed by this data as well. And I think it is important for the non-dermatologist to think about, I think this is potentially different than what we're seeing in our, RA population, right? When we're using drugs like methotrexate and such. So, I do take this seriously. I think most of us follow LFTs very carefully, of course. If, I'll say this is a theme of collaborative management. Certainly I'll rest on the liver doctors and GI doctors' input as well. But we follow LFTs very carefully, and I'll tell you that we also utilize some newer methods like liver, ultrasound elastography, MR elastography. If folks have persistent elevation, of course, of LFTs, if they're very high risk, for my diabetics and morbidly obese patients, I find those helpful in trying to risk stratify folks and make me feel more comfortable over long periods of exposure to drugs like methotrexate. I'm curious to hear what Evan does and what you do in this regard as well.
Yeah, I would say I follow a pretty similar pattern as you do. I follow LFTs fairly closely. I'd say every 3 months for sure on patients. To be honest, I grew up checking LFTs probably every 6 to 8 weeks on patients on methotrexate based on the anxieties of the dermatologist when I first started using this. I think we assuaged those somewhat, but I still check them about every 3 to 6 months depending on the activity and how long I've been following the patient. Certainly once they start to have abnormalities, if there are abnormalities, even mild ones, I watch them a little bit more closely. Usually get a liver ultrasound at that point to start off with, and then I would again put in that plug for co-management, because once those LFTs are still more elevated, particularly if I'm not using a drug like methotrexate, so we're really dealing with somebody who has LFT abnormalities or liver non-alcoholic fatty liver disease just based on their underlying disease process, that's when I get them over to gastroenterologists that specialize in liver disease and try to co-manage with them.
Sounds good. Thank you. So mental health is another comorbidity. I probably don't have to spend a lot of time on this. I think this has been really well known. I think the question is, how do we screen for, depression? I think many of us, probably pick up a lot of nonverbal cues. Here are some studies really just highlighting that up to 16% of psoriasis patients could meet criteria for major depression. So definitely something we should, screen for in our practice as well. Similarly, we can see in this study for psoriatic arthritis, major depression is also increased for this group as well. So the next couple slides are going to be on the GI complications, which I think many of us also know about. Here you could see a list of not only just the inflammatory bowel disease, but also irritable bowel, celiac, and peptic ulcer disease is also common. We know that there's mechanisms that are similar to what Evan had talked about in the pathophysiology, can also spill over into the gut, increase intestinal permeability, the microbiome, as well as infectious theories that can lead to worsening colitis as well. So here we see that in a big cohort, once again, just to highlight that psoriatic disease and IBD can go together. And the more severe your psoriatic arthritis and psoriasis is, the higher your chance of having inflammatory bowel disease as well. Cancer, it's hard not to mention cancer. This is always an ongoing study. There's a lot more done in rheumatoid arthritis than in psoriatic arthritis. But here we see a slight increase of cancer overall in psoriasis, while in psoriatic arthritis, because the studies are a lot smaller and not, able to have as many studies, we are unfortunately not able to see much of a difference for the psoriatic arthritis group, but it's always good to keep in mind cancer screenings, age-appropriate screenings as well. So I just wanted to end, I think we touched a little bit about overcoming the gaps in wellness in general. This is a passion of mine, really trying to study more about wellness strategies and how it might affect not only to improve patient outcomes, but also the way that we can really be impactful for these patients. And what are the barriers to this? So for physicians, it's probably because it's not as prioritized. We have so many other things to think about. Screening for other comorbidities, as well as treatment options, optimizing their treatment. Sometimes we may be unconvinced by the data that we see out there because it's not as peer reviewed in terms of wellness strategies. And, we also lack the skills and the time to move some of these forward. And on the patient side, so it's not just the physician side, they need to sort of accept this kind of education, right? So it's much easier for them to learn in pop culture what they might want to do. It's hard for them to distinguish what is marketing, what is science, the lack of money and lack of time as well. But always important to keep in the back of the mind, we're trying to close that gap between the patients and physicians and to understand this key challenge. So in summary, I just wanted to review that comorbidities, it's important for you as clinicians to be aware of the relevant ones that we mentioned. Screening is also important, and not only for the patient outcome, but also for the selection of therapies. And co-management, I think, is really important. So we touched upon looking at different comorbidities and whether or not we'd get GI involved. How do we even think about the other disciplines, such as a cardiologist, that will get involved as well to help improve our outcomes in comorbidities. So this is a great segue for our next module, so please stay tuned. We have Dr. Joe Marola, always an entertaining speaker, who's going to take a deeper dive into the co-management issues in psoriasis and psoriatic arthritis. So thank you so much for your attention.